Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Jason Van Tassel. Dr. Jason Van Tassel is a San Diego native and attended San Diego State University, graduating with honors with a Bachelor of Science in Biology. Dr. Van Tassel attended Georgetown University School of Medicine, located in Washington, D.C. He graduated with honors in 1997, being admitted to the Alpha Omega Alpha Honor Society. He was then accepted into the Head and Neck Surgery Residency program at the University of Arkansas for Medical Sciences. Upon completion of his residency, he joined the faculty at the University of California, Irvine in the Department of Facial, Plastic, and Reconstructive Surgery, completing a fellowship in 2003. He is currently board certified in ear, nose, and throat and facial, plastic, and reconstructive surgery. Dr. Van Tassel practices medicine at Washington Township Medical Foundation in Fremont.
I'm just going to go through a couple things with you guys today. I'm going to try to keep it simple and make it a talk that I think that would benefit the layperson, as well as people whom are in medicine. My practice isn't a static practice. It has evolved quite a bit since I first got out of my residency. And what I do now looks nothing like what I did 10 years ago in terms of the surgeries that I do and the approaches that I take to obstructive sleep apnea. So with that, just a little introduction. What is OSA, or obstructive sleep apnea? And as most of you know, it's basically a cessation of breathing with respiratory effort that lasts greater than 10 seconds. There are a couple of subtypes. There's obstructive apnea, there's obstructive hypopnea. And hypopnea is a little bit less severe. It's where you sort of breathe a lot less than you normally would with a decreased airflow of greater than 70%. And then any decrease in saturations. And so the way that we sort of figure out, well, how bad is my sleep apnea, doc? What's it going to be? Is we add the apneas and the hypopneas together and we get a calculation. It's called an index. And we get this from a sleep study that's performed either at home or in a sleep lab. Okay? So in terms of the significance of sleep apnea, it's considered mild, moderate, and severe. Patients with mild apnea are considered patients whom have a respiratory distress index. That is, they stop breathing or their breathing slows down between 5 and 15 times an hour. Moderate is 15 to 25, and really anything above 25 is considered severe apnea. Normal, at one time when I first graduated from my residency, was considered less than 10. And then they revised it because they found that it does actually have significant health benefits when you have mild sleep apnea. So who's got it? About 40 million people in America have it. 40 million people in the United States have a chronic sleep disorder. 20 million have it sometimes. And so the sleep disordered breathing group is snoring and sleep apnea. About a quarter of the population that are males have it. 9% of females have it. And then in patients with significant sleep apnea, about 10% of males have it, and 2% of females. The implication is that if you leave sleep apnea untreated, today, tomorrow, next week, next month, nothing's probably going to happen to you. And so this is one of the tricky things about sleep apnea. It's kind of like smoking was back in the 1970s. It's like, well, You know, the cigarette isn't going to kill me today. The cigarette isn't going to kill me tomorrow. But in 20 years, it's going to have a pretty significant impact on your health with regards to COPD or lung cancer. And the same applies here to sleep apnea. Patients with severe sleep apnea, I'll just whip out my handy-dandy laser pointer here, over 15 years of follow-up, which, as all of us know, really isn't that long these days. This 15 years can go by pretty fast. The survival is pretty significantly diminished in untreated sleep apnea. Patients with normal sleep have some mortality. Mild to moderate sleep apnea have more, but the really dramatic difference is seen in patients who have severe sleep apnea. And that usually takes two forms. One is the heart attack, and the other is a stroke. So there's a study that this guy did a number of years ago, and he looked at about 100 patients who had a sleep study, and he followed them for 5 years. And so in the patients that had sleep apnea, 46% of them died, and only 16% of the patients who didn't have sleep apnea died. So that kind of just drives home that there is a significant impact on your health in the long term. It's also an independent risk factor for stroke. In a similar study, they looked at strokes among patients with sleep apnea that was untreated versus those that did not have sleep apnea. And in the study of 128 patients, 62.5% of them with an apnea hypopnea index greater than 10 had strokes over the time that they followed these patients. So it's pretty significant. In terms of the symptoms that people have when they have sleep apnea, the most common complaint among adults is fatigue. Sometimes you'll see morning headaches, irritability, short-term short-term memory loss, intellectual deteriorations, temperamental behavior, job performance problems, dry mouth, impotence, and then mouth breathing. The sites of obstructions are many. The principal area of obstruction is typically in the back of the throat, and this is where most treatment has sought over the history of surgery and non-surgical approaches to sort of address this area of the tongue, the palate, and the uvula. This is the area where there's a confluence of obstruction that prevents air from getting through when you're asleep. When you're upright during the daytime, you have good physiologic muscular tone, you're awake, you're moving around, and so the breathing is usually not a problem in the daytime. But at night, when you're relaxed, and especially when you're on your back, which is probably the worst way you can sleep when you have sleep apnea, all of the tissues kind of crowd the back of your pharynx back here and cause obstruction. The body overcomes that obstruction because your body's not going to let you die. But what it requires to overcome that obstruction is basically you have to wake up. And you have to release a lot of chemicals in your bloodstream in order to make that happen. Epinephrine, norepinephrine, all the things that are bad when your brain and your heart are deprived of oxygen because it makes your heart beat harder and faster. And it's like having already run a 100-yard dash and then expecting it to do it again. And that's why there's a predisposition to have heart attacks when you have obstructive sleep apnea. But the areas in question are the nose, which is, if it's obstructed, can certainly cause snoring and can contribute to sleep apnea. Soft palate, which is probably one of the most common areas. The base of tongue and the airway, this is an evolving area of medicine. Well, I didn't finish my training that long ago, but during one of the last years of my residency, this is probably around the year 2000, we still thought that tongue-based obstruction and hyoid or upper airway obstruction only represented 1% of obstructive sleep apnea. And we found that it may represent up to 50%. And a lot of this had to do with the fact that we didn't really have anything to treat it. Okay? The techniques for treating hypopharyngeal, this tongue-based lower airway stuff, really didn't come about and become popularized until after probably the mid-90s to the early 2000s. This is just another depiction of normal breathing during sleep as opposed to obstructed breathing during sleep. Okay? There's a bunch of testing that we do to determine the level of obstruction. And this is more of a slide that is for residents that I sometimes teach. But when you look at a physical examination, you can see a lot of things. Just for orientation, this is the tongue, this is the uvula, this is basically the McDonald's sign. These are the tonsils in the back of your throat. And obviously, these tonsils are big. This patient's palate isn't particularly long, but the uvula is not particularly long either. But in this case, the obstruction is caused by the tonsils. And we'll see a couple other examples today. But tonsil size has a lot to do with obstruction, and that is why kids very often have obstructive sleep apnea, because they have very large tonsils, and they either get them out when they're kids, or they slowly shrink when they're an adult, so it doesn't cause as much problem. But when you look at other issues, you can also look at tongue position, and this is a huge thing in sleep apnea because the treatments that involve the palate will work in these patients, but if you do the palate-only procedures in these patients, it won't work. So as the tongue gets bigger, the problems get harder to solve. But we have solutions for them now. This is another example of a patient with just gargantuan tonsils. I think he snored when he was awake. This is a patient with a very long uvula, and it's hard to sort of see it, but the palate goes all the way down past the tongue, and we're pushing the tongue down. And you can just see the uvula sort of plunging down into the throat and the hypopharynx. Sometimes when you look from behind, when you look down at the uvula, you'll see the uvula is so long, they can almost swallow it sometimes. So, and this is another example of a patient. This patient was actually a patient of mine, and that is just one big tongue. So you see a lot of variability, and so one size fits all is not something that you can use when the treatment of sleep apnea, whether you're taking an approach of a medical treatment and medical therapy or approaching patients for surgery. So the majority of what I'm going to be talking about is what I do, is the surgery. But I think it bears in mind that we should probably address the other options too. The one that I left off is the doing nothing, because I would imagine that if you really wanted to do nothing, you wouldn't be here today or be watching this video, whichever forum you're seeing this in. But the gold standard for the treatment of sleep apnea for years has been a CPAP mask. And CPAP has come a long way. At one time, they were the size of a pretty large suitcase, and they were not portable. The systems were clunky. The masks were ill-fitting, and they caused a lot of problems because they weren't as easily adjustable. Things have come a long way, though, and so the masks fit better. The devices are literally the size of a laptop now, and so people can travel with them. And for the right patient, the CPAP still remains the gold standard. But there are a lot of people out there who can't tolerate CPAP, or who, for whatever reason, don't wear it. For every 3 people that have CPAP, there are probably 2 whose CPAP sit in the closet because they don't use it every night, or they put it on, they try it for a few hours, they roll over in bed, it leaks a couple times, and they just rip it off. So there are numerous studies that exist in the literature that look at compliance for CPAP. Some people quote 60%. Some people quote 50%, but it can be as low as 30%. So if you're only having 1 in 3 people who have it use it, you're not really getting much benefit. The next treatment that is used that is also non-surgical is an oral appliance. And these have become popularized probably in the last 5 to 7 years. What it does is it's basically a night guard that you wear, which is it's kind of like braces, but it's putting your jaw into a position where your jaw is thrusted forward a little bit to open up the back of your airway. And these can be custom fitted by a dentist. We make them in our office for the right patients, and they can be highly effective. Again, there's an issue of keeping it in all night. People tend to spit them out. the dog eats it, you name it. But, and so it also, because you're causing the jaw to come forward, it can lead to some problems with temporomandibular joint disorders and basically jaw problems in your joint. It does work. This is one that you may have seen online. It's a little bubble that sucks on, you suck it on your tongue and it kind of holds your tongue forward so you can't swallow your tongue. But these are, take a lot of different forms. They're mostly indicated for patients who have mild to moderate sleep apnea, because as you get into the worsening sleep apnea problems, it's just you can't move the jaw forward far enough with these dental appliances. Okay, so these do have a role in the treatment of sleep apnea for patients who don't want to use CPAP or are not interested in surgery. Bringing us to some of the compliance issues with it. About 60% compliance, which is probably better than the CPAP. So it was the opinion of this one doctor that it was worse than surgery because only 60% of the people used it. So, which brings us to what I do, which is the surgical considerations. So when I see a patient who has sleep apnea, we do a pretty thorough evaluation of their structural anatomy of their nose, their throat, and their hypopharynx to sort of figure out what is it that needs to be addressed, what is it that needs to be moved around, what are the considerations here. And I can't specify this enough, but every patient represents a unique problem because there's no airway that is exactly the same. We tailor the procedures to the patients. We have a number of procedures that we can choose from to address the different areas. The uvulopalatal is a common term that is thrown around for sleep apnea surgery, or UPPP or UP3, and that's for the most part kind of the workhorse procedure that's been done for 40 or 50 years since it was first introduced. The hypopharyngeal surgery, which I'll talk about a little bit as well, this is kind of an evolving surgery, and it has an evolving role. And so we'll talk about that a little bit in just a few minutes. There are a lot of surgical options. Pillar implants are these little implants that you can actually put in the palate that were originally thought to be beneficial for snoring and somewhat for sleep apnea. They've sort of fallen out of favor. The main procedures that I do are the uvulopalatal, and I do a variant of that called a lateral pharyngoplasty, and then a couple tongue-based procedures. There you can break the bones in the face, you can saw the jaw and saw the maxilla and move it forward with plates. I think that that's a fairly extreme procedure in most patients, although some, but most patients don't need that level of invasiveness. And then the ultimate treatment for sleep apnea is a trach, where you just make an incision in the neck. I probably have 1 or 2 patients in the last 15 years of my practice who's actually said, yeah, doctor, I want a trach, or a patient who's come to me who had already had one for their sleep apnea. They're happier than you would think they would be. But again, that's a pretty extreme measure to take. So in terms of the uvulopalatal pharyngoplasty, which is the common procedure that I perform, whether it's performed alone or in conjunction with other sleep apnea procedures, in general, it's the most common procedure performed for sleep apnea. And the worse the sleep apnea gets, the worse this works alone. So in patients who have severe apnea, you really need to look at other procedures. There are 2 studies that were done, one in 1994 and the other one in 2004, which showed that you can get up to 80% success rate. You really got to be careful who you choose to do the surgery on. Okay. And what a traditional uvulopalatal pharyngoplasty is where you remove the tonsils and you trim the palate and the uvula, and then you sew it all up. One of the major issues regarding uvulopalatal pharyngoplasty is that it's thought that, or it has been thought by physicians who perform the procedure, that the principal cause of sleep apnea is too much mucosa. You just have too much, tissue in there. And so if you cut some of it out, you'll fix the problem. And that works, I think, up to a point. The problem with the traditional uvulopalatal is that this uvula, it actually does something. When you yawn or you make certain expressions and certain sounds with your voice, your palate contracts and it rises. And when you have no uvula, it forms a scar band here, and so you end up with this fixed band. And sometimes food will go up your nose, and in some patients, everyone kind of complains that they feel like there's something stuck in the back of their throat. And that might be because of the scar contracture that's there, or it could be that the fact that there is something there and the uvula isn't there to sweep it off. I don't chop the uvula off. I leave it. And I'll show you an example of a case that I took pictures of to sort of demonstrate it. This slide is just going back to talking about this Friedman classification, where if you take a patient with this type of an airway or this type of an airway and you do a UP3 on them, they do great. If you do this patient or this patient, they don't do so great in terms of success. So you need other procedures to address these types of patients that have severe apnea or have airways that have significant compromise. What I do in terms of the procedure that I choose to do to achieve the palatal problem, or to correct the palatal problem of sleep apnea, is what's called a lateral pharyngoplasty. This was originally described by a guy named Colley in 2003. He presented it at one of the national meetings. And what he does is, instead of cutting out the mucosa and suturing, he actually cuts the muscle and repositions the muscle. And he got a good improvement. So in his study, there's a bunch of people who had sleep apnea, and their average respiratory distress index, or apnea number, was 41. And afterwards, it was 9.5, which is pretty good. You got to select these patients well, but it does improve things. So I don't do mine this way. I do it slightly differently. My view is that the problem in the throat is dynamic. It's secondary to lax muscles. And some people's muscles are just in the wrong position, or they're too loose. And if you tighten things up, it won't collapse as easily. And so I don't cut as much mucosa. I spare mucosa. I spare the uvula. And we do what's called a dynamic repositioning of the muscles that are underneath. The focus of my surgery is not on excision. You can't put stuff back once you cut it out, like the uvula, for instance. It's more on repositioning the muscles of the pharynx, which have really long names. So I use this in mild to moderate sleep apnea, and I also use this in conjunction with other procedures that we'll talk about in just a few minutes. So this is a picture of a person who had sleep apnea that I operated on last year. And they had what I would consider moderate sleep apnea. As I recall, their respiratory distress index number was about 30. So this patient's an adult. They have some tonsillar tissue. They have this posterior fold of mucosa, and they've got a fairly normal-sized uvula. This is the tongue down here. So after I took the tonsils out, whoa, scary, bloody stuff. You can see the striated muscles underneath, okay? And you see here the uvula is still there. I took a little bit of the excess mucosa off because it tends to get swollen from snoring and obstructing over the time. So you just trim the tip off but leave the muscle behind so that the whole physiologic complement of the uvula is left. And then what I do is I take sutures and I reposition this underneath. And I reposition all these muscles laterally so that if you're trying to obstruct, it's harder because the muscles, they just don't come in as much. So I do a multi-layer closure of this area, as opposed to most doctors just kind of put the mucosa back together and that's kind of it. And one of the reasons that I started doing this was not because I originally thought it was a muscular problem. What I noticed is that when I just sewed the mucosa, it often tore and was ripped open. So I said, well, let's put another layer of suture in, which was a deviation from what most people do. So I started putting in sutures in underneath to try to see if I could get more of it to hold together. It did hold together better, but what I noticed also is that I could sort of determine where I wanted to put these muscles and sort of help kind of open things up. So as you see, it's a lot wider through here compared to the preoperative state, which is right here. This is the difference between this and this. And this state closed, they occasionally still will rip open, but even if they do, the effect is is a lot better, because when they typically, when this incision line opens up, you don't open up both layers. You tend to just open up the top layer, and the muscle, which is the most important part, tends to stay closed. So that's uvulopalatal and then this other part is tongue base and hyoid stuff, which is kind of further down. This has kind of been my baby since about 1985. I was in Los Angeles in practice, and I was at Santa Monica UCLA Hospital doing a surgery on an 80-year-old lady who had had horrific sleep apnea for years. Everybody knew her because you could hear her sleeping in her apartment because the snoring was just heroic. So the representative from the company who sold the tongue-based advancement system that I was using at the time came in and said, hey, you should try this out on a patient. I tried it out. And it worked so well that they thought she had died because she made no noise anymore. And so that had kind of a profound effect on me, in that there was this lady who had really severe sleep apnea. I don't recall specifically how severe her apnea was in terms of her numbers, but she had a cure, and this would have been someone who was not curable without this new technology. And so overall, it is estimated that about 75% of patients who have sleep apnea would probably benefit from some sort of procedure that involves the tongue base or the hypopharynx, which is everything that's kind of back beyond the palate and down into the throat. These areas are hard to get to, though. And so there's a lot of different ways you can do it. You can put little probes in the tongue and shrink the tongue. Some people's tongues are very muscular, like buffalo meat. And when you cook buffalo meat on barbecue, you'll notice it doesn't shrink very much. But if you were to cook like a tri-tip that's very marbled on the barbecue, you'll notice that when it's cooked, it's like half the size you started with. And the same thing applies for the tongue. Some people have fatty tongues, and in those patients, this procedure is actually very effective because you shrink the tongue and increase the volume of the hypopharynx, just like cooking something on the grill. You can also just remove it directly by performing a midline glossectomy. You can take the mandibular bone where the tongue attaches and saw it, and then pull it out and flip it sideways and secure it into place and drag the tongue attachments with it. And that is called a genioglossus advancement. And this is probably the precursor to the tongue-based suspension and the hyoid suspension that I do. You have to saw the jaw and make a hole in the mandible, which theoretically can lead to a weakened jaw because it has a big window in it now. That hasn't really been the case or been really shown in any studies. But to achieve the same thing, you could also just advance the tongue with this tongue-based suspension. I'll kind of give you an idea how that's done. And then hyoid suspension as well. And all these numbers are numbers from different studies. And so as these lower numbers tend to be standalone procedures when they just did this and not with something else. And these higher numbers tend to be studies that were done when they did it in conjunction with the uvulopalatal. Okay? So, and this is where my numbers are right here, 78, 82. And I'll show you the actual data that I've collected. Tongue-based suspension, just a quick overview. It's minimally invasive. It takes about 30 minutes to do in the operating room. You're usually there for the uvulopalatal already, or the patient has already had that and has not been effective. When I've done the tongue-based suspension alone, patients say that on a scale of 1 to 10, it's about a 3 in terms of discomfort. These patients, of course, are patients who've previously had a uvulopalatal which is a hard procedure to go through and is very painful. It can be performed in conjunction with the UPP or as a single procedure, usually after they've failed the UP3 alone. Okay? It has an increased success over the UP3 alone, and that's because it's probably the patients weren't candidates just for a UPP alone. The one disadvantage of this tongue-based suspension thing is that the coverage by medical insurance is mixed. It's been around since the mid-90s, but for whatever reason, politics often gets in the way of medicine. And so many carriers, this is changing, but many carriers have considered investigational, so these procedures tend to be hard to get approved. What it is it's an incision that is performed in just a little cut under the chin, and then you deploy these sutures. And these sutures go through the tongue in kind of a special way so that they support the tongue. And the sutures are thick, so it's not just going to like kind of cheese wire through the tongue like it's going through some brie. So that it is able to hold the tongue forward and prevent it from falling back. This is the technology that I use. It's called the Siesta Encore system. And there's another system that's out there that's made by Medtronic that looks a little bit different. I switched to this because this is adjustable. I switched to this because the company hired me to help them develop some other products. And this actually is an invention that I made and have patented for another procedure that we'll talk about in a second, which is the hyoid procedure. But the tongue-based suspension is performed through a little incision under the chin, and you just dissect down and then deploy the sutures, and then the sutures come out, and then you secure them to the screw. And if it's not tight enough, you can bring it back. If it's too tight, you can loosen it. I've not yet had a patient who's asked me to loosen it. I potentially have a couple patients who could use some tightening. This device is the prototype for passing the suture that is for hyoid myotomy and suspension. So this brings the tongue base forward so you don't have as crowded of an airway posteriorly when you're sleeping. This gives about an 80% cure rate if you define your cure as a respiratory distress index of less than 20. It's less if you make it so that your RDI is less than 5, but that makes sense. There's some long-term clinical results. This was the classic study that was done. This gentleman, Vincente, is out of Torino, Italy, and did an excellent study looking at patients that had uvulopalatal and tongue-based suspension. And they had a considerable improvement in their pre- and post-operative studies. So preoperatively, they were 52. Post-operatively, their average was 14.1. And so the cure rate was 78%, which is pretty remarkable. Historically, and even today, a lot of people, when you ask them about sleep apnea, they think that surgery for sleep apnea has a success rate that is less than 50%. This is not 50%. This is quite a bit better than 50%. These are some other studies that were done that looked at cure rate, and these were 6 months post-procedure. This study had the longest follow-up. The next procedure is a procedure that has evolved for me over the last 2 years because I couldn't get the tongue-based procedure approved. And it's called a hyoid myotomy and suspension. It's performed the exact same way through the small incision in the neck. And what it does is instead of moving the tongue forward, it moves the hyoid forward. And it just so happens that the tongue attaches to the hyoid. So you're moving that as well. It's also minimally invasive, and it tends to work best in patients with moderate to severe sleep apnea that have a flat epiglottis. So you draw the entire airway forward back here and open up this posterior area by moving this forward, also done through a small incision in the neck. This is just an example of a lot of different configurations of the epiglottis. Some people's epiglottises are flat, some people's are really rounded, And you see a lot of variation. And this is something that's not been well described or well understood, but we're getting an idea that patients with a flat epiglottis are ones that need the hyoid. And so much like the tongue-based suspension, the hyoid just draws the entire airway anteriorly to open up this posterior channel so patients can breathe and not obstruct while they're sleeping. Oftentimes we'll do the hyoid in conjunction with the tongue-based, done through the same incision, takes a few minutes more. So this is my actual data that I've collected over the last year, and this one patient really stands out and really bothers me because the pre-op and the post-op went the wrong way. But the post-op one, they made her sleep on her back, which is where her symptoms are worse. So we're going to repeat it and let her do a sleep study in the wild, as in at home. And I think that what we'll see is that instead of being up here, it'll be down here. Sleep studies that are performed in laboratories are usually performed under a pretty strict set of parameters. And one of them is that when you're attached to all this equipment, they want you to sleep on your back. And that's because if you sleep on your back, you're going to have less of a tendency to flap back and forth and disturb the equipment and disconnect it. But also what it does is it tends to make your sleep apnea look worse. And so this patient in particular, I think that she was, kept on her back where this is the last place that she should be. She's feeling better. But even in patients with severe sleep apnea, all the way down, this is another one, all the way down, pretty pronounced improvement. So this is data that I'm going to be presenting at the American Academy of Otolaryngology Head and Neck Surgery in the fall. Actually, it is the fall, so next month. It's kind of my warm-up talk. The published evidence with hyoid is about 65%. My experience, and I have about 27 patients whom I performed this on sequentially since I started doing the hyoids last year, is about a 78% reduction. Okay? So if you define the success rate of sleep apnea treatment as being greater than a 50% reduction in the sleep apnea number, the respiratory distress index, and also that the postoperative RDI has to be below 20, you get about a 90% success rate, which is a lot different than what you'd see with just uvulopalatal alone or in patients that were studied historically before we really had a good understanding as to what's going on. And this continues to evolve. The techniques that we're doing today will probably look different than what we're going to be doing 10 years from now as we gain a better understanding. In fact, there was just a recent new product that was released by the FDA for use. It was approved by the FDA. It's by a company named Inspire. And it is, in fact, a pacemaker which goes next to one of the nerves in your tongue and stimulates it. And so it turns on that muscle so that it's basically awake at night so you don't sleep. And in their hands, in their studies, they get about a 62% improvement. So I think that they haven't quite yet figured out who the best candidate is and how to market it. So I think that's something that's a little bit further down the road. But for right now, the best bet, in my opinion, without doing anything that's really invasive, such as breaking the jaw and the maxilla and wiring the jaw shut for 3 months, is a combination of a palatal procedure that is not excision-based but is suspension-based, is a dynamic muscle sling surgery, tongue-based suspension, and hyoid myotomy and suspension. So surgery for sleep can be successful. It's not 50-50 proposition, as some would suggest. And often it takes multi-level surgeries. And these multi-level surgeries can be done together. They can be done separately. You've never really burned all your bridges. There's always something else you could try. People tend to do one procedure and give up. But if you're committed to getting your sleep apnea better, it's worthwhile investigating, reinvestigating, and taking second and third looks at things. That is all I have. Everyone, thank you very much.